I'm Dr. Ken Landau. Thanks for watching. Let's talk about panic attacks and panic disorder. These are two of the most common problems in psychiatry, cause frequent visits to general practitioners' offices and to emergency rooms. It's estimated that about 25% of people who go to the emergency room complaining of chest pain actually are suffering from panic attacks. Panic attacks are a type of anxiety disorder associated with intense fear and anxiety. It's accompanied by physical symptoms. Well, you get an abrupt surge of intense fear or anxiety or discomfort, reaches its maximal intensity within several minutes, and you have to have at least 4 different specific sets of physical symptoms that accompany the panic attacks. And these include the sensation of palpitations or pounding heart or fast heart rate, or they could be sweating or trembling or shaking. Could be a sensation of shortness of breath or smothering, or feelings of choking or chest pain or discomfort. Other people complain of nausea or abdominal distress or feeling dizzy or unsteady. Another set of symptoms are lightheadedness or fainting, feeling like you're going to faint. Some people complain of chills and hot sensations. They develop paresthesias, that's numbness and tingling in the extremities. Some people complain of a feeling of unreality, call it derealization, or a feeling that they're detached from themselves, depersonalization. Some people fear that they're going to lose control or go crazy, and other people fear they're going to die. Frequency of the attacks could be several times a day, or it could be a few attacks every year. They occur without warning. The first attack, however, typically is provoked by some stressful situation. Then the subsequent attacks, well, they just seem to come without any specific provocation. Now, the attacks are embarrassing. People fail to tell their friends. What could the trigger be for the initial attack? Well, the trigger could be giving birth, having surgery, general anesthesia. Maybe it's prolonged stress, or taking amphetamines or cocaine or THC, using some of the hallucinogens, or maybe having an asthma attack or COPD or depression. Times it's associated with the SSRIs, the selective serotonin reuptake inhibitors like Prozac, which also happens to be a treatment for the condition. Could be withdrawal from the benzodiazepines, again, another treatment for the condition, benzodiazepines. Could be discontinuation of a sleeping pill, general medical condition, maybe you had too much caffeine or cocaine. You have hyperthyroidism. Maybe it's got something to do with vestibular dysfunction, Meniere's disease, partial complex seizures, pheochromocytoma, a rare condition of the adrenal gland. Might have something to do with social anxiety disorder. So in social anxiety disorder, person is afraid of situations where they might be scrutinized, like public speaking. Now, interestingly, as we've learned more about panic attacks, it seems that even though they tend to come on, the symptoms come on very acutely, we know that about an hour before the panic attack begins, there are subtle waves of change in the patient's breathing and the patient's cardiac function. And this leads to autonomic nervous system symptoms of arousal that occur for the hour before the attack. The person could have a slightly increased heart rate, altered breathing. The person tends to breathe shallower, so the CO2, the carbon dioxide, tends to build up in the system. That can lead to the onset of symptoms. Once the symptoms begin, they tend to last for minutes to hours. Overall, the average is about 20 to 30 minutes, maximal intensity within about 10 minutes of the start. Well, the DSM, Diagnostic and Statistical Manual, says panic disorder is recurrent, unexpected panic attacks that are followed by at least 1 month of having persistent fear, persistent concern that you're going to have more panic attacks, and having the fear change your behavior so that you avoid situations where you think that the attack might occur. Well, when the attacks do occur, remember, it's physical symptoms, not the cognitive symptoms. So when we talk about panic attacks aren't limited to panic disorder. So you can have panic attacks without a panic disorder. They occur with other anxiety disorders, mood disorders, psychotic disorders, substance abuse. Person can have a panic attack under special circumstances. So panic attacks, you fear heights, you fear snakes, you fear spiders. Those people who are then exposed to those situations can have symptoms of panic attack. And people who have post-traumatic stress disorder, well, they can have the same sort of symptoms, don't realize it unless you do a very careful history. So the condition itself, the panic attack, panic disorder, is not benign. It alters the quality of life and leads to depression in some people, and then can interfere with your work environment, leads to absenteeism, interferes with their career advancement, or leads to disability in some people. And some people, because of the fear, turn to either alcohol or substance abuse. Well, you can even have panic attacks while you're asleep. They occur about 25% of the time. Same characteristics as the daytime panic attack, same kind of response to therapy also. Well, at the diagnosis, it's rare to have the panic disorder without other kind of psychiatric abnormalities. We call them comorbidities. So people with panic attacks, panic disorder tend to have depression or anxiety or bipolar disorder or alcohol abuse. About 90% of patients have those kind of problems. Now, they differ from an anxiety attack. Some people talk about anxiety attack. That's not even a specific disease. But certainly panic attacks are much more severe than what most people refer to as an anxiety attack. An anxiety attack tends to be associated with restlessness, maybe a little shortness of breath, increased heart rate, difficulty concentrating. And the problem with the panic attack, panic disorder, is the doctor needs a high index of suspicion. Because a lot of people go to see the doctor and they don't complain, hey, I have panic attacks. What they do is they complain, I have some kind of pain, I have sleeping problems, I have some sort of somatic issue, I have shortness of breath, I have heart-related problems, or I have dizziness. It's estimated that many as 25% of people complaining of dizziness actually have panic disorder, panic attacks. So these are individuals who have multiple recurrences over time. These people have chest pain and palpitations and difficulty breathing and choking sensation, sweating and paresthesias. And what they do is they travel from doctor to doctor to doctor, and they see specialists and general doctors. They get lots of tests, lots of office visits, sometimes even hospitalization. The differential diagnosis is, well, does the person have panic attacks, or is it generalized anxiety disorder? Is it agoraphobia, social anxiety disorder, bipolar disorder? Is it a factitious illness or obsessive compulsive disease or PTSD? Or did the person just drink too much caffeine? Or is the person suffering from hyperthyroidism or hypoglycemia? Or maybe the person has pulmonary emboli or temporal lobe epilepsy. Maybe the person's withdrawing from opiates or sedatives or alcohol. Well, all of these things need to be considered. Otherwise, the person is going to overuse healthcare resources and have lots of procedures, lots of tests, and lots of expenses. Well, there are other kind of comorbid conditions, other than the ones that I mentioned, that are also associated with panic attacks and panic disorder. So mitral valve prolapse and hypertension and asthma and COPD and Meniere's disease and migraine headaches and irritable bowel syndrome and tension headache and chronic fatigue. In fact, it's estimated that almost 100% of people with panic disorder, panic attacks, have at least one of these comorbid problems, with depression occurring in about 50% of the people. If we look at the demographics, seems that panic attacks are less common than generalized anxiety disorder or PTSD, tend to occur mostly in European Americans rather than African Americans or Asian Americans or Latinos. If we screen the general population, about 1 to 3% appear to suffer the condition. But if we go to a general practitioner's office and survey the patients seeing the doctor, about 3 to 8% suffer the condition. And it seems to have a bimodal peak. So the onset tends to occur in adolescence or early adulthood, but then it also tends to occur in people in their mid-30s. Well, there seems to be some evidence that as a person gets older, the attacks become less frequent or non-existent, and that probably has to do with some age-related changes inside the brain. Well, childhood panic. It's a legitimate problem, but it's unreliable to say that if a child has what we would consider panic attacks, that they're going to continue on into adulthood. Now, if we examine a person who has panic attacks but isn't having an attack at the time, physical examination is basically relatively normal. Can suffer the typical diseases depending on the age of the individual. At the time of an attack, a person has increased heart rate, increased blood pressure, tremor, shaking, but they have normal judgment, they have normal insight, they have normal thought process. If the thought process isn't working properly, then the person probably has some other kind of disorder. The concept, well, we think emerged about 25 years ago with the publication of the American Psychiatrics DSM-3, but really the accounts go back a heck of a lot longer, go back to the 1800s with DaCosta's soldier's heart in the wartime, or Wheeler's neurocirculatory asthenia, or Lewis's effort syndrome. Originally, all of these had to do with the military. There was an implicit role for significant stress and trauma. Probably that's the overlap between PTSD. What's the underlying cause of panic attacks? Genetics has a lot to do with it. Environmental factors have a lot to do with it. We'd think that there might be some chemical imbalance in the GABA or the cortisol or the serotonin or the noradrenergic system. Think that certain areas of the brain might be hyperexcitable, might have some sort of abnormality in the endogenous opioids. Those are just guesses. They don't really have any firm basis in reality. Some people think it's an abnormality of the glucose metabolism in the amygdala or the hippocampus or the thalamus, or maybe a decrease in the orbital frontal blood flow, maybe a decrease in the density of the benzodiazepine receptors. But those are just guesses. So overall, we think heredity has maybe about 40–50% to do with it. So we know that if you have a primary relative who has panic attacks, you have an 8-fold increase in the risk. So in other words, overall, about a 40% chance of having the diagnosis, with monozygotic twins, identical twins, having the condition more commonly than non-identical twins. Well, in some people, it might be just an internal sensitivity where you recognize abnormal heart rate, abnormal respiratory rate, and your brain makes something more out of it than it really should. Well, other people think that it might have something to do with the perinatal period, and it might have something to do with the acquisition of different bacteria in your intestine. So we know that fecal transplants that occur from high stress to low stress mice, not in humans obviously, in mice, we know that that can increase or decrease the stress level of the recipient. So the recipient of the fecal transplant of high anxiety mice, they develop high anxiety. So it seems, and there's good reason to believe that some of it may well be true, that the gut microbiota, the bacteria in the gut, seem to regulate the brain function through what we call the gut-brain axis. And if you have an abnormality of those bacteria are making a lot more serotonin and a lot more noradrenaline and a lot more of the neurotransmitters than our brains do. Because you have to realize that on a cell basis, there are more of the bacteria in the gut than there are cells in your human body. So, what we can say is that some people like to split diseases, and they like to link them to other things. So we have some people who are labeling certain groups as having panic attacks with bipolar disorder on the basis of genes, and other people say linked to cigarette smoking, again on the basis of genes, or interstitial cystitis on the basis of genes. All of that seems to be going a step too far at the present time. Now, we also have another condition. It's a related condition, and it's called agoraphobia. It's a different condition. It's an extreme form of public avoidance. People fear being in crowds, standing in line, shopping in a mall. They have the added complication that most of the people who have agoraphobia also have panic attacks, panic disorder. And as a matter of fact, we rarely see agoraphobia without panic attacks, but it may come on before the panic attacks in up to a third of the individuals. Now, the same sort of initial stresses seem to be associated with agoraphobia. It's a fear of open spaces, but it's not really a fear of open spaces, what the word means. What it really is, it's a fear of having a panic attack when you're in a crowd or in a car on a busy street or in a bridge or a tunnel. You're attending a performance in a movie theater or a closed stadium, crowded stadium. You fear those places because you can't escape. And that's basically what agoraphobia is. And the situation can occur several times a week, or it can occur relatively frequently, and then you can have periods when you don't have any of the attacks. Tends to be more common in women by a factor of about 3. Estimated, if we look at all the people who have panic attacks, probably about a quarter of them have agoraphobia. In the previous edition of the Diagnostic and Statistical Manual of the American Psychiatric Association, it was thought that agoraphobia was just a qualifier for panic disorder. But now the current edition says it's an independent condition, independent of the panic disorder. Well, is it common? It's pretty common. Occurs in about 1.5% to 2% of the general population. Most of the people who develop agoraphobia develop symptoms before they're 35. Average age of onset is about 17. Supposed risk factors are all those kind of non-specific conditions that psychiatrists like to talk about. Well, parental overprotection, or maybe childhood fears or terror or grief from bereavement or traumatic childhood, but those don't really seem to make any sense. The likelihood of remission is less than about 10%. It's less if the symptoms tend to be worsened, if you also have an anxiety disorder, if you suffer from depression, if you have personality disorder, or you suffer from substance abuse. It's important to recognize that agoraphobia is not a benign condition because it may be associated with depression in a significant number of times and may be associated with suicide attempts in about 20% of people with agoraphobia. Well, there are two questions to ask people if they're potentially suffering from panic attacks or panic disorder. And the questions have good sensitivity and poor specificity. So one of the questions is, in the past 6 months, have you ever had a spell when all of a sudden you were frightened or anxious or very uneasy? If you answer yes to that, well, you need to be evaluated for panic attacks. The other question is, in the past 6 months, have you ever had a spell where for no reason your heart suddenly began to race, or you felt faint, or you couldn't catch your breath? If you answer either of those two questions positively, then you have a fairly good chance of suffering from panic attacks, panic disorder, but that's not sufficient to make the diagnosis. Now, there's some evidence that it can go into remission after several years, maybe about 25% after about 3 years. And certainly it's much higher in people who only suffer from the panic attacks or panic disorder without all of those other comorbid conditions that we mentioned. Well, how do we treat the condition? Well, always the same kind of story. Exercise can decrease stress, get sufficient sleep, do some breathing exercises, avoid recreational drugs, tobacco and alcohol, don't have too much caffeine, perhaps consider a support group. But really, if you have mild to moderate disorder, then either drug therapy or cognitive behavioral therapy or psychotherapy. If it's severe, then probably drug therapy with either an SSRI, selective serotonin reuptake inhibitor, like Prozac or Paxil or Zoloft or Celexa, or an SNRI like Cymbalta, Effexor. Or you could consider a tricyclic antidepressant, imipramine, amitriptyline, or benzodiazepine like Klonopin or lorazepam. It's said that the SSRIs have fewer side effects and they're better tolerated than the other drugs. I'm not so sure about that. Well, one of the treatments can be breathing training. You can have biofeedback. And that's helpful for some people. Cognitive behavioral therapy, it's certainly talked about as if it's a miracle cure, but the data really isn't robust. It's kind of soft. And in addition to all of that, there's relatively few trained individuals, and most people are more familiar with the drug therapy. So if we talk about the SSRIs, those are the drugs that I mentioned. Seems that there's no evidence that any one of the drugs is better than any other drug. So if you happen to pick the paroxetine or you happen to pick the Celexa, it's just as good as the Prozac. Seems to have a moderate to a large improvement effect compared to a placebo. Also helps with other mood disorder. We said that it's very frequently associated with depression. On the other hand, person can do just as well with the Effexor, maybe the Cymbalta, some of the other drugs. Drugs like trazodone or buspirone don't seem to work nearly as well. The tricyclic antidepressants, they work quite well. On the other hand, they have some more side effects. Those are drugs like the zipramine, nortriptyline, imipramine. The MAO inhibitors can be useful in those people who are resistant to the other kind of therapy, but they have more side effects, so we try to avoid them. Benzodiazepines, well, if you happen to have a very severe attack, they work much more quickly than the SSRIs, so you might want to consider starting with a drug like Klonopin or diazepam or lorazepam, even alprazolam, Xanax. But they're certainly not effective if a person has major depressive disorder. But the benzodiazepine is very effective. They start working within several days to a week. Seem to be better tolerated than the SSRIs. And even though they're not recognized as first line of therapy because of the potential for abuse, well, many people don't seem to do quite well enough on just the SSRIs and still need a benzodiazepine in addition. In Europe, the regulators say long-term benzodiazepine should not be used for panic attacks. The American Psychiatric Association over here says the fears are overblown. There are a lot of benefits. Overall, somewhere between about 50 and 80% of the people with panic attacks are going to improve with either the benzodiazepines, the tricyclic antidepressants, or the SSRIs. Treatment is going to be quite effective, so much so that a significant number of people go into remission for 6 months at a time. Unfortunately, if you discontinue the therapy, probably somewhere between a quarter and a half of the people who are in remission are going to have flares. Well, if you're going to come off of the drugs, probably do it relatively slowly. If you start taking the drugs, well, you take the drugs for 6 to 8 weeks before you change the therapy, because some of the drugs, especially the SSRIs and the SNRIs, take some time to work. Drugs like gabapentin and the anticonvulsants, they just don't really seem to work. The beta blockers, again, they don't seem to work very well. Psychoeducation, correcting the misconceptions, identifying the distortions and thinking about the attacks, that's all very important. So the more you know about the condition, the better off you happen to be. Now, a lot of people who have panic attacks, they tend to breathe very rapidly and very deeply. That's exactly the wrong thing to do. It's better to breathe shallow and to breathe regularly. So you want to have a constant small stream of air going through the nose. Sometimes even just use a paper bag And then in addition, if you happen to have panic disorder, panic attacks, you want to have a plan. You want to have a friend that you can call that can distract you. Maybe you focus on the breathing, where you breathe in for 4 seconds, hold it, and then breathe out for 4 seconds. Try muscle relaxation. Try a mantra saying, this is temporary, I'll be okay. You focus on some kind of an object. And that's the story, basically, of panic attacks and panic disorder. They're relatively frequent. They oftentimes come along with another condition called agoraphobia. We don't know the cause. Seems that genetics plays a role, and in some individuals, we believe, or we're starting to believe, that dysbiosis, some abnormality of the gut microbiome, might have something to do with it. But the first thing is to recognize the symptoms that you suffer might actually be related to panic and not something wrong with your heart or something wrong with your lungs or something wrong with your intestine. And then go see the doctor and make certain that you help him or her understand that in your particular case, hey, this is recurrent, this is a condition that I think is associated not with something wrong with my heart or something wrong with my lungs, but this seems to be related to the anxiety family, panic attacks and panic disorder. But remember, if you suffer from this condition, probably have a variety of other emotional conditions or psychiatric conditions as well. Now, fortunately, therapy seems to work. How long you stay on the therapy, that's another issue. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.